our season with Lecture 6, presented by Dr. Catherine Caldicott. Some housekeeping issues before we start. Just a note about questions and comments. Please put all of those in the chat, and we'll hold them until the end of the presentation tonight. All of you attending this evening will be sent a link in the next couple of days to the CME questionnaire. And I think you probably all know the drill. Complete the questionnaire, submit it, and you'll receive your certificate within 7 business days. Everybody should have my email address, so if you have any issues or problems, obviously reach out to me, and I'll be happy to help. Absolutely. So tonight, we are so happy to have Dr. Catherine Caldicott with us. Her topic this evening is early intervention to distressed clinicians, avoiding board and NPDB reports. So who's Dr. Caldicott? Here she is. Dr. Caldicott, FACP, is the medical director of PBI Education. She's an internist with nearly 25 years of experience in ethics education, remediation, coaching, and research. At PBI, she works closely with course participants and referring entities alike. She trains faculty to teach intensive remedial courses for clinicians and oversees online preventive courses and topics relating to professional conduct. She served as an invited subject matter expert on the Federation of State Medical Boards work group on physician sexual misconduct. Dr. Caldicott is regularly invited to present on professional ethics, boundaries, civility, and communication, and trauma-informed regulation by regulators, professional groups, and hospitals across North America. Dr. Caldicott graduated from Princeton University and Dartmouth Medical School. She completed in her internal medicine partnership at Yale and residency at the University of Michigan, where subsequently she was a Robert Wood Johnson Foundation Clinical Scholar. Her publications have appeared in Academic Medicine, Medical Education, Ethics and Behavior, the Journal of Medical Regulation, and the Journal of Law, Medicine and Ethics, among others. We are so honored and fortunate to have Dr. Caldicott here with us this evening. Please join me in welcoming her. Dr. Caldicott, thank you so much.
Oh, thank you too, Margaret. I'm so delighted to be here. Thank you for the invitation. And thank you to all of you showing up on a random evening. And so I appreciate your attendance. I'm going to start sharing my slides and let's get started. Okay, so you heard the title, Early Interventions for Distressed Clinicians, Avoiding Board and NPDB Reports. So you may be wondering lots of things about this topic. What is distress? Why do we care? How does distress manifest itself? What are early signs of distress? What is the mechanism for developing distress? What is the rationale for early intervention, and what do those early interventions look like? By the end of the hour, I hope you'll feel better equipped to answer these questions. Now, throughout, I'm going to use the term clinician in order to make this presentation more broadly applicable, even though I realize that most of you are or have worked with physicians. So first, I will start with an illustrative example. Dr. AB is a real person, but I've changed some details to protect their identity. Dr. AB is a 48-year-old intensivist who was on the front lines during COVID. Their long hours away from home and job stress exacerbated an already tenuous marriage. Dr. AB developed a friendship with another staff physician that included conversations, text messaging, and email messaging during the most intense COVID years. Inexplicably, the other physician abruptly stopped communicating with Dr. AB, sending Dr. AB into a panic. Dr. AB repeatedly and insistently continued to reach out to the other physician via text and email at work. Eventually, the other physician reported Dr. AB to Human Resources. Dr. AB's hospital privileges were suspended pending the outcome of an internal investigation into violations of the Institutional Code of Conduct and anti-harassment policy. The investigation found that Dr. Abe's conduct with their colleague constituted disruptions to professional operations in violation of institutional codes and policies. They were issued a letter of expectations in which they were prohibited from having any further contact with the colleague and were warned that formal disciplinary action could occur if the prohibition were violated. Unfortunately, Dr. AB again resumed sending email messages to the colleague in violation of the letter of expectations. The hospital terminated Dr. AB's privileges and reported this to the State Medical Board and the National Practitioner Data Bank. Then, the licensing board summarily suspended Dr. AB's license pending an investigation into Dr. AB's fitness to practice with reasonable skill and safety. Dr. AB's DEA registration was suspended due to the board action. Dr. AB's Medicare enrollment was suspended due to the DEA suspension. And then the board referred Dr. AB to their state professional health program for case management and support. The PHP recommended an intensive remedial course in professional boundaries with a longitudinal follow-up component, and that is how I got to meet Dr. AB. In my roles at PBI, besides teaching courses, I also do one-on-one coaching with licensees. I train our faculty and staff. I communicate with referring entities such as regulators, employers, and professional schools. I collaborate and advise on developing hospital policies for chaperone use and performance improvement plans. And I give presentations such as in-services, grand rounds, conferences, and special programs like this one. Before I describe what it was like to meet Dr. AB, I should explain what an intensive remedial course is like, as some of you might be unfamiliar. Intensive remedial courses are quite different from the usual courses a licensee takes to comply with continuing education requirements or to pursue continuing professional development. Intensive remedial courses can last days. Attendance is typically mandated by a regulator or employer, or urged by the attorney representing the course participant. Remedial courses cover topics such as ethics, professionalism, boundaries, civility and communication, risk management, record keeping, and prescribing. Enrollment is limited to small groups, typically about a dozen in size. There is generally one designated faculty member so that they can gauge course participants' development of insight and degree of success in applying the course content to the reason why they are taking that course. Active participation in discussions is expected, and open disclosure of what happened and the backstory is required. You can imagine that it is important for the course provider and the faculty to create a safe, trusting environment so that participants feel they can say what they need to say in order to learn and practice their profession more safely in the future. It won't surprise you that there is a strict confidentiality policy. It is possible to fail a remedial course, so simply showing up is not sufficient. During the intensive professional boundaries course that Dr. AB took, they felt safe enough to disclose elements of their life that contributed to their many boundary violations. Certainly, they violated their colleagues' personal and professional boundaries, but they also violated the boundaries set forth in the Institutional Code of Conduct, the Anti-Harassment Policy, and the Letter of Expectations. Those life elements include what we call in our courses vulnerabilities. That is, intrinsic issues that increase the risk of committing a professional violation. One example would be underlying mental health issues. Dr. AB told the class that throughout their ordeal, they just thought they were a bad person who could not let go. Think about what that must have been like to have heard that. After the ordeal was over, they realized they clearly needed help and didn't see until it was much too late that they should have sought help long before the situation at work spiraled out of control. Their mental health issues long predated the situation at work. They used the excuse that they were just too busy to get help for their many years of depression and anxiety, made worse by their PTSD from being on the front lines during COVID. In addition, they believe they lack the skills to identify and read other people's facial expressions and emotions, which they reported had caused misunderstandings in other aspects of their life. Finally, a lifelong people pleaser, Dr. AB has always struggled with saying no, and this caused them to fail to set important boundaries both at work and in their personal life. Other underlying issues in Dr. AB's situation constitute what we call in our courses risk factors. For example, being in a field such as intensive care medicine, where the stakes are extremely high and the stress was particularly acute during COVID. Witnessing being unable to help so many patients, especially those whose loved ones were prohibited from being with them at the end, lacking adequate personal protective equipment, working when feeling ill and exhausted, and when there were too many patients for the hospital's small team of intensivists. As if that weren't enough, Dr. AB's marriage was tenuous. They had family members with significant financial needs who Dr. AB was trying to support. One was a family member with a life-threatening medical illness. Other family members had recently lost their home to a fire and were staying at Dr. AB's home for the foreseeable future. And if you think that constellation of issues is unusual, it is not. Most of the people who come to our courses have stories very much like this one. Finally, all of these issues succeeded in making Dr. AB feel extremely isolated. We know from decades of working with licensees who commit professional misdeeds that isolation, whether it is geographic, professional, or personal, is an extremely potent risk factor for improper conduct. So what is distress? Some of this content I have borrowed from the Tennessee Medical Foundation. First, it's important to frame a discussion of distress as a descriptor of behaviors rather than of people. The person likely has underlying issues that manifest themselves in behaviors that run counter to the efficient and respectful provision of healthcare. Also, chronicity is important. Everyone has bad days. There may be rare or occasional outbursts due to fatigue or other stresses, and the clinician recognizes that their conduct was inappropriate for the workplace. That's not what we are talking about tonight. More troubling conduct can include a wide range of words and actions. For example, inappropriate anger or resentment, inappropriate words or actions directed toward another person, and inappropriate responses to patient needs or staff requests. All of this results in a work environment that is unproductive at best and hostile and unsafe at worst. So why do we care about distress? Well, I think these reasons are self-evident, and you can probably come up with other reasons that I haven't listed. But for example, again, distress creates a hostile, unhealthy clinical environment. It hampers teamwork, lowers morale, erodes trust, provides or produces an unhealthy learning environment, impairs collegiality, causes worse patient outcomes and worse patient and family satisfaction. So what leads to distress? Well, let's start by talking about addictions. These could be chemical or behavioral. I worked with a clinician who took several of our courses and our longitudinal follow-up course called Maintaining Accountability with Support, or MAS. And this clinician had a gambling addiction. They stayed up all night to gamble, so were chronically sleep deprived. They got into a lot of debt, which caused them to sign up for more work shifts, which perpetuated the unhealthy cycle. Sometimes undiagnosed or untreated medical or mental health issues can manifest themselves as troubling behaviors. I am sure you're all familiar with the stigma surrounding mental health concerns among clinicians, even now, even in 2025, despite all the publicity about the high rate of suicide among clinicians in general, but physicians in particular. It won't surprise you that this professional culture causes many clinicians to go either undiagnosed or untreated, or to self-medicate, or to seek care from a colleague who wants to be a pal and write them a prescription without doing a formal workup. Personal problems, such as relationship, financial, family, or legal problems. The distressed clinician may have been acculturated during their training to handle everything without asking for help. Or they may never have developed good coping skills, so that when challenges such as family strife or illness arise, they internalize their emotions, which then come out inappropriately at work. And some clinicians with distressing behaviors actually have a bona fide personality disorder, so this is something to keep in the back of your mind. What else leads to distress? Well, I have a lot of items here listed on this slide, and I'm going to go through them one by one. So let's start with the cold versus hot states. This terminology comes from very interesting work by Professor Dan Ariely, who is in the Behavioral Economics Department at Duke University. And he wrote about it in this great book called Predictably Irrational. You can easily find a free PDF to download online, and I highly recommend it. It's a fascinating read. Professor Ariely's thesis is that every clinician, every single one, will behave irrationally in a predictable way given the right set of circumstances. So that means that in some circumstances, they are in what he calls a cold state. And an example of a cold state is what we're doing right now. We are thinking rationally about concepts and experiences. Our emotions are not engaged. We are considering possibilities, alternatives, and ways forward. But sometimes, in fact, many times, we get ourselves into a hot state. We all get ourselves into a hot state when decisions must be made quickly or when emotions are heightened or unsettled. But here's the fascinating thing about Ariely's research. He took one group of study participants. They were smart, rational people. He administered a test that presented hypothetical scenarios and asked them what they would do in those situations. In a cold state, they answered one way. They believed that they understood themselves and what actions they were capable of. But then Ariely got these people into an emotional or hot state. In the hot state, these same people answered the same questions very differently, showing that they underestimated their reactions and could not predict the degree to which emotions would change them. So what kind of emotions are we talking about? Emotions could be from the present or the past. They could pertain to your professional life or your personal life. They could involve transference or countertransference. Now, I suspect all of you in the audience know what transference and countertransference are, but I like to make sure that everybody has a common understanding. So let me just give a definition. So when a patient typically, or a coworker or a student, projects their own emotional reactions or unresolved conflicts inappropriately onto another person, such as the clinician, that can lead to a reenactment of that unresolved emotional material. And that's what we call transference. Countertransference is the same kind of dynamic, but in the opposite direction. So when the clinician projects their own emotional reactions or unresolved conflicts inappropriately onto another person, which can lead to a reenactment of that unresolved emotional material. And that also remember that emotions need not be negative to cause us to behave irrationally. Even positive emotions that come from getting a new job, moving to a new house, getting married, having a baby, getting a promotion, all have the potential to push us into a hot state if we do not remain mindful. Now, the lesson here is not that we all should behave like unemotional robots. Rather, the lesson is to know ourselves well enough to anticipate situations when our emotions can get the better of us, can impair our decision-making and ability to interact reasonably. This requires awareness and practice. Okay, The next thing I want to tell you about is the PBI formula. And even though I can't see your faces, I know your eyes are glazing over. I can tell. Trust me, in 5 minutes, this figure should make intuitive sense to you. So this is what we call the PBI formula, and we teach it in all our intensive remedial courses. It is not an arithmetic formula. It is a symbolic way of depicting the interactions of multiple factors that can take a clinician from having the potential to commit some sort of professional violation, like acting in a distressed way, to actually committing that violation. The formula relies on the premise that every clinician, no matter how smart, well-educated, well-trained, accomplished, or well-meaning, has the potential to mess up. I am using the strong term violation here because many of those mess-ups end up violating some aspect of the Clinicians' Professional Practice Act, whether it be their State Medical Practice Act, a State Nursing Practice Act, or a State Psychologist Practice Act, for example. The goal is to keep the violation potential, the VP in this diagram, low. It can never be zero. The kinds of clinicians you all are concerned about with the distressing conduct have already committed some sort of violation, whether it be a violation of institutional policies or codes of conduct, or a professional code of ethics. And we are trying to keep them from committing a violation of their Professional Practice Act that would necessitate a referral to a regulatory board or the NPDB. I'm going to walk you through all of these different elements. RF stands for professional risk factors, VUL stands for personal vulnerabilities, A stands for accountability, C stands for catalysts, and R stands for resistance. If you think about the relationships among risk factors, vulnerabilities, and accountability, you will realize that the greater the risk factor and/or vulnerabilities, the higher the violation potential, unless it is offset by a robust set of accountability measures. Where accountability is robust, that might be sufficient to offset lots of risk factors or vulnerabilities. Now, the little r that stands for resistance is depicted as an exponent, and that is meant to denote that resistance is a very powerful elevator of a person's violation potential. Okay, we're going to look at each one of these elements one by one, and when we do, I want you to think back to the story of Dr. A.B., or think about other clinicians you know who have been labeled as distressed. Okay, so first we're starting with risk factors, and by risk factors I mean external stressors, stressors that are extrinsic to the clinician. For example, clinical specialty. Does it have the potential to become intimate over time, such as in psychiatry or primary care or gynecology? Is it a hands-on specialty where patients might not understand the rationale for the physical touch? Is it one where the clinician-patient relationship lasts for a long time, such as in family medicine? Is it a specialty with intensity, such as intensive care or cardiac care? Patient type can increase risk, especially if the patients are particularly vulnerable, such as in mental health, pediatrics, or geriatrics. Work situations that carry more risks include small communities where it is difficult to avoid dual relationships, rural communities where there may be only one clinician in town who handles everything, as opposed to areas where there is a wider variety of specialists and subspecialists. Isolation. The big one is solo practice. And I mentioned this earlier as a very strong risk factor for committing a professional violation. But there is also geographic isolation and personal isolation. Reducing isolation is an important part of keeping clinicians practicing safely. Excessive workloads are a setup for impairing a clinician's judgment. The workload can lead to time pressures. Financial pressures might be driving the excessive workload. Family issues can result if the clinician is never home. But family issues can also include family illness, marital strife, being in the sandwich generation where the clinician is caring both for their own children and their parents, and so on. Cultural, generational, and gender differences can be at the root of impaired communication, implicit bias, and misunderstandings that can lead to a hostile work environment. So thinking back to Dr. AB, they were overworked in an understaffed setting during COVID where they were on the front lines. They had financial stress from caring for other family members. They had a seriously ill family member and marital trouble, and they felt extremely isolated. Lots of risk factors. Now, by vulnerabilities, I mean stressors that are intrinsic to the clinician. For example, personality type. Some clinicians are people pleasers, rescuers, or cannot say no. They want to impress or fear asking for help. These issues often are developmental, rooted in childhood experiences and relationship dynamics. Again, thinking back to Dr. AB, they were a self-described people pleaser who couldn't say no. They had long-standing mental health issues that were inadequately treated. They described difficulty with reading others' faces and emotions, making you wonder whether they could be described as neurodivergent. I want to go into a little more detail here about vulnerabilities. Here are some clues you might consider to underlying issues that might be at the root of distressed conduct. Now, this is not to encourage you to jump to conclusions or make assumptions about these clinicians or to label them with diagnoses without a bona fide assessment. This is to suggest that there may be more going on than meets the ear. And that's the important point to remember. If so, a formal medical or mental health evaluation may be appropriate. And if there is more going on, that may be what is at the root of their inappropriate conduct. So some examples would be if there's a clinician who uses a lot of profanity, maybe they have impulse control issues and might make you wonder about a diagnosis of ADD. Or someone who behaves with righteous indignation or they're very inflexible may have perfectionistic tendencies or defensiveness that would need to be investigated. I would be remiss if I didn't mention the role that a history of trauma could play as a vulnerability that could elevate a clinician's violation potential. There are many definitions of trauma, but I think this one from SAMHSA is a good one. Trauma is an event, a series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or threatening, and that has lasting adverse effects. Notice that this definition is rather vague and broad, but that allows it to account for the variability of how different people experience things. Also notice the enduring fallout of having experienced something as traumatic. Well, how common is a history of trauma? At least 70% of adults in the US and Canada have experienced at least one traumatic event in their lives. Examples of trauma can include military service, abuse, whether it was physical, emotional, sexual, or even at the hands of another healthcare professional, dissolution of a significant relationship, loss of a loved one, particularly if it was unexpected or a child or through violent crime, accidents, institutionalized racism, or generational trauma. And let's not forget the vicarious trauma that some clinicians experience on the job, especially if they work in places such as emergency departments. But some traumas occur in childhood. The Adverse Childhood Experiences, or ACE questionnaire, is a 10-item questionnaire that asks about abuse and household dysfunction experienced by people before they turned 18. A yes answer to any of the questions is considered positive. 12 to 17% of adults in the US have experienced 4 or more positives on the ACE questionnaire. Now, you might think that an ACE score of 4 sounds high, but the picture of someone with this kind of history doesn't look all that unusual. Here is a hypothetical example. A child may have grown up in a household where they experienced verbal abuse and emotional neglect, and they may have had one or more family members in the home with alcoholism and mental illness. Well, why is it important for you to be mindful about trauma in clinicians with troublesome conduct? First of all, there are several articles that show that exposure to ACEs may contribute to a person's desire to enter a healing profession. But one study published in Academic Medicine in 2021 found that 22% of physicians and medical students with professional violations in the areas of boundary violations, disruptive behavior, substance use disorder, difficulties with collaboration, heightened responses to stress, and trouble benefiting from feedback had an ACE score of at least 4. Notice that the 22% is much higher than the 12 to 17% prevalence in the general population. This list of professional violations probably looks very familiar to you, especially given your concern about and interest in clinicians who are considered disruptive. Okay, we're back at the formula. I've described risk factors and vulnerabilities. Now let's look at accountability measures denoted by the letter A in the formula. As you can see, if accountability measures are lacking, then the violation potential will go up. But if accountability measures are robust, they can lower a clinician's violation potential by offsetting the effect of risk factors and vulnerabilities. There are many ways to bolster professional accountability. Just a few words about some of these. Peer consultation, as long as the peer is someone who can be honest and not tell the clinician what they want to hear. Chaperones, sometimes called clinical observers, people who serve in this role should be trained, and I can tell you a bit about the training if you are interested. They must not be family members or friends of the patient. Unless there is a mandate for a designated chaperone, scribes and clinical assistants can serve as a chaperone, and they are very cost-effective. Self-care includes a lot of things: attending to physical and mental health concerns, getting care from appropriate clinicians in an office with a chart, just like any other patient, and not seeking quick favors from coworkers. Sleep hygiene, of course, a tough one for clinicians with a punishing work schedule. Relationship health, going to therapy if needed. Spiritual health. Activities away from work, such as hobbies and opportunities to socialize with other people. Of all the changes that our remedial course participants commit to, those in the area of self-care are always the most numerous. And an accountability buddy. This could be someone at work, or a friend, or a family member. But this is a person the clinician can trust to discuss the kinds of things that get under their skin, or who they can talk to about how they handled certain situations and ways they could have done better, as long as the accountability buddy understands the history of inappropriate conduct and what is at stake if the conduct doesn't change. The clinician should check in with their accountability buddy on a regular basis. And if you think back to Dr. A.B., they had neglected their self-care for a very long time. Okay, back to the formula. If you look at the upper right-hand corner, you'll see a lowercase r, which denotes resistance. We depict resistance as an exponent to indicate how powerfully it can increase a clinician's violation potential. You also see r to the r power. That denotes the subgroup of people who are unwilling or unable to recognize their resistance. They are at particularly high risk for committing a professional violation. So what is resistance? Well, maybe the clinician is unable or unwilling to fully acknowledge their professional role. Or maybe they are ignorant of or choose to ignore the legal or regulatory context of professional work. How do we describe resistance? Well, this list looks a lot like defense mechanisms: denial, repression, defensiveness, rationalization, justification, intellectualization, minimization, other blaming, wishful thinking. And so you can see that the lack of insight or ability to self-reflect puts blinders on a clinician who then is unable to appreciate the effect of their conduct. And finally, we are at the last element of the formula, and that is the catalyst. So violation potential is only a potential. It takes a catalyst to propel the clinician from having a high violation potential to actually committing a violation. Examples of catalysts include being suddenly propelled into a hot state, significant life events or transitions. I discussed having a history of trauma as a vulnerability, but a sudden traumatic event can propel a person to commit a violation. The seductive patient doesn't necessarily have to be sexually seductive. I have worked with clinicians who committed violations as a result of being intellectually seduced by a patient who is interested in their work or who had interesting scholarly or avocational work of their own. And thinking back to Dr. Aby's case, I think that COVID qualifies as a trauma, a transition, and a crisis that brought about a lot of loss. So let's talk about recognizing early warning signs of distress. I'm sure most of you are familiar with the metaphor of a slippery slope. This is PBI's interpretation of it to show you that committing a violation rarely comes out of nowhere. What I want you to take away from this sketch are two things. First, excuse me, that violations are almost always preceded by lesser misdeeds. Our labels here of drift, crossing, and transgression are meant to help explain that. Drift is a mental process, not an action. If we think back to Dr. A.B., they were thinking about their coworker in a certain way before they initiated the communication. Had they not had the coworker on their mind, they would not have begun to message them. The second thing I want you to take away from this sketch is that the slope gets steeper the farther down you go. That is meant to depict that the risk of harm to all parties involved and to their relationships with each other increases when improper conduct progresses from less serious, which we call crossings, to more serious, which we call transgressions, and finally to violations. This is a continuum that sometimes is only appreciated in retrospect. A clinician like Dr. A.B. started out at drift, then began their crossing with multiple text and email messages. Nothing terrible happened, so that became the new normal. But then their coworker withdrew. By then, Dr. A.B. was incapable of seeing that they were sliding down the slippery slope. Similarly, there is no bright line separating early from late warning signs. Having said that, I will give you examples of what warning signs look like. Because drifts are thoughts, you likely won't be aware of these. However, for the future, if a clinician has an accountability buddy, these are the kinds of things they can discuss, potentially leading to distressing conduct. So not being careful in their thinking about their role definition. Not paying attention to when they are stepping outside their role-related behavioral boundaries. Entertaining private thoughts about others for their own pleasure rather than in the service of patient care. Having fantasies such as a rescuer or a savior fantasy, not just a romantic fantasy. And then thoughts that might reflect assumptions from past experiences or biases. All right, so we've gone from drift, now we're going to crossings. What are some examples? Well, flouting rules and requirements around timeliness and documentation, not adhering to schedules, being unreliable, acting outside the scope of their clinical role and their clinical training. Sometimes crossings can be harmless, and it depends on the context. So for example, hugging a long-standing patient or a coworker goodbye before they relocate across the country. So of course, context matters, but history also matters too. If the clinician you are concerned about has a pattern of doing something that doesn't seem quite right, you might consider it a red flag, whereas it wouldn't be a red flag in someone who you never had any concerns about. And then microaggressions. So for example, you speak Spanish? Funny, you don't look like you speak Spanish. Or two white surgeons discussing the merits of the Civil War in the presence of a Black physician assistant, or the use of sarcasm or eye rolling. Now, some of these examples I just gave may actually cause considerable harm and be considered transgressions, but sometimes they may not cause that much harm, in which case you could call them crossings. So, causing more harm, transgressions. So examples, disclosing current desires or current personal difficulties. In other words, inappropriate self-disclosure. Sometimes clinicians rationalize that their self-disclosure enhances rapport with patients or coworkers and makes them seem more relatable. But that's an example of how resistance works, because they are not appreciating their professional role and power dynamics and not engaging in self-reflection. And then the clear violations, examples like yelling, throwing things, using profanity would be examples of lack of impulse control. Physical assault, bullying, refusal to cooperate, making others feel unsafe. Obviously, these are the things you want to avoid. So now let's talk about the rationale for intervening early. All of this may be self-evident, but it's worth describing. You want to avoid the progression to more serious offenses. You want to avoid more serious repercussions, and they can be many. For example, potentially losing an otherwise valuable member of the clinical staff, particularly at a time of global workforce shortages, with all the financial, time, and human costs involved in reassigning that person's clinical load, paying premiums for locums or travelers, recruiting and onboarding. Disruptions to patient care and team functioning, financial, family, and career hardships for the distressed clinician, and tarnishing the reputation of the organization. You also want to set an institutional tone that is constructive. You want to allow the so-called improved clinician to serve as a positive role model. And you do want to preserve and potentially even improve careers. Now, the subtitle of this talk is Avoiding National Practitioner Data Bank and Board Reports, which themselves have all sorts of consequences. So what kinds of things get reported to regulators and to the NPDB? Well, professional review actions based on reasons related to professional competence or conduct adversely affecting clinical privileges for at least 30 days, and voluntary surrender or restriction of privileges while under or to avoid an investigation. So what do early interventions look like? Here's a first step. Many of you may be familiar with the work of the team at Vanderbilt to approach unprofessional behaviors. This is from their 2007 paper that describes an early intervention, the cup of coffee conversation. This is a collegial, respectful conversation where the offending clinician is made aware that their behavior was observed and came to attention as being potentially unprofessional. Their perspective is elicited, and then a plan is developed with the goal of no further recurrences. However, they also learn that if there are recurrences, formal discipline may result. The cup of coffee with a peer is a response to a single incident or allegation. It could be the result of a misperception, so your investigation should be able to suss that out. Document everything. And just so you know, this is not the appropriate approach for egregious, prohibited, or unlawful conduct. So again, one early intervention, the cup of coffee with a peer. Another would be to track and document subsequent complaints. So for example, was the clinician responsive to the cup of coffee conversation? Are any complaints that were filed after the cup of coffee conversation took place actually about issues that predated the cup of coffee? Good documentation will allow you to get a good picture of the clinician's conduct over time, and that will position you to assess whether their conduct is escalating or whether they responded to counseling and other lower-level interventions. Then, is there an apparent pattern emerging? You get to decide what constitutes a pattern. Is it 2 occurrences or more? I think it is reasonable to consider a pattern, or at least to explore what is going on and to discuss with the clinician that you are concerned about a pattern. We have an expression at PBI that immediacy matters. In other words, there are all sorts of intuitively obvious benefits to intervening early. For example, early intervention reduces the risk that additional problems will occur. It closely connects the intervention with the behavior. It prevents resistance from becoming entrenched. It accelerates improvement, and it hastens the process of repairing and restoring team function. These interventions that are listed on the slide can stand alone or be part of a workplace performance improvement plan. The remedial education I am talking about is not your usual CME and certainly not an online course or a webinar. I'm talking about the intensive remedial courses like the ones that Dr. A.B. took. I do want to add that sometimes the PHP will make specific recommendations also, depending on the results of assessments. So consider just a few more words about remedial education interventions. So you could think about them as your remedy, and a course that you choose to send the person you're concerned about, to send them to, should require that the participants recognize, accept, and address the drivers of the conduct, that they tell their story honestly to their classmates, that they develop a plan of action for addressing the elements of their formula or the reasons what that conspired to cause them to have the distressing conduct, and then also to have the option of engaging in a follow-up component. To further highlight that remedial courses are not like usual CME courses, the FSMB, the Federation of State Medical Boards, publishes and regularly updates a directory of the many assessment programs and remedial courses that are out there. And in case you're working with clinicians who are not physicians, don't worry. The directory will be a good resource for you too. We take all clinicians in our courses, both from the US and Canada, and do not segregate them by profession. So if you're interested in the directory, just go to fsmb.org and type remedial programs into the search bar, and you'll get the most recent iteration. I want to take a couple of minutes now to discuss an approach to clinicians with distressing conduct. You are likely familiar with trauma-informed clinical care, and some of you may also be familiar with integrating a trauma-informed approach in your work. For example, the Maryland PHP is very committed to this. I want to make the case that a trauma-informed approach is the best way to handle clinicians with distressing conduct. And here is how I got to this perspective. In 2019, I heard Nancy Oglesby and Mike Milner from Justice 3D present at an Administrators in Medicine conference, and then again in 2023 at a conference of the Council on Licensure, Enforcement, and Regulation, or CLEAR. Among the many things I found so compelling about their presentations was their report of the good results of taking a trauma-informed approach in cases of domestic violence. It turns out that healing the abusers, a restorative approach, reduces recidivism significantly. It seemed reasonable to me to extrapolate that experience to clinicians with distressing conduct, and it turns out that there is some good work in this area from a regulatory perspective. Taking a more compassionate approach to regulatory processes has been shown to support clinician well-being and avoid certain serious, negative, albeit unintended consequences. I want to read a quotation from an excellent article that makes this point. The article is Virtually Daily Grief: Understanding Distress in Health Practitioners Involved in a Regulatory Complaints Process. So here's the quotation. There has been growing concern globally about the association between regulatory complaint processes and the mental health and well-being of the practitioner who is subject to a complaint. Previous research suggests that health practitioners involved in such a process can experience heightened levels of distress, anxiety, and shame, which impacts their personal lives and their families, as well as their professional identity and practice. There have also been tragic cases of practitioners involved in complaints processes who have died by suicide. This message circles back to some of the reasons why you would want to intervene early in cases of distressing conduct. We are experiencing a global workforce shortage in healthcare, but early interventions using a trauma-informed approach just might save lives, careers, might prevent that long list of adverse consequences I presented to you many slides ago, and prevent recidivism. The PHP sent Dr. AB for an intensive mental health evaluation that concluded they are currently not fit to practice and identified mental health issues that merited intensive treatment, a medical workup, and additional testing and longitudinal therapy after the intensive treatment program was completed. When I described to you earlier what I do in my job at PBI, I mentioned that I train the faculty and the staff. I've done different kinds of training with them, but the one I want to tell you about here is a trauma-informed approach. After hearing the Justice 3D presentation in 2019, it reinforced that a punitive approach to licensees who may have committed professional violations is not the best way to achieve insight, growth, lasting change, and a safe practice. Incorporating a restorative trauma-informed approach to how our faculty teach our courses and how our staff interact with our course participants has enhanced our ability to assist in this kind of professional transformation. To be clear, a trauma-informed approach does not mean going soft on a licensee or making allowances for improper behavior. It is a way of digging into the underlying reasons why an otherwise capable and well-meaning clinician failed to exercise good judgment. Every participant in a PBI course must develop their own personalized protection plan in order to graduate. Components of the protection plan include changes the participant will make in their work environment, professional conduct, and personal situations that will support them and help them prioritize the wellness that is essential for practicing safely. Because Dr. AB's medical license is still suspended, they developed a now and a later plan. The Now plan lists several items, including continued mental health care and efforts to obtain non-clinical employment to ease their current financial stress. The Later plan, for after their license is hopefully reinstated, also lists several items, including continuing mental health care, but with time off work to attend appointments. Dr. AB recognized that being overworked was a big risk factor for them even before the COVID pandemic and decided that they would set boundaries on their work hours regarding call and coverage. They also plan to identify a mentor in any new workplace who they will inform about their background and story so that the mentor can act as a sounding board for issues, problems, and triggers. This plan will be revisited and updated during the longitudinal follow-up course as circumstances may change or new issues might arise. Unfortunately, Dr. AB did lose their job. Even if their job had not been terminated for cause, Dr. AB still would have had to step out of practice for some time until they were deemed fit to practice again. But by being fired, Dr. AB had no opportunity to say goodbye to patients and colleagues. They felt further isolated and had no closure. But one outcome of this experience was that Dr. AB learned about self-compassion in the Professional Boundaries course. Self-compassion is not the same as making excuses for improper conduct. It is a healthy way of relating to yourself when dealing with difficulties and distress, which we all face, and it involves accepting ourselves as flawed, imperfect individuals with self-kindness. We have found that self-compassion is a critical skill for course participants to learn. For example, as you might imagine, when intelligent, highly trained, skilled, and well-meaning professionals commit some sort of improper conduct, they go through phases of coming to terms with what they have done. They go through stages of personal and professional rehabilitation that begin with confronting their misdeeds, feeling shame and being in crisis, grieving the many losses, like the loss of public trust, potential loss of their career, perhaps loss of family relationships, reputations, or standings in their communities, and even the loss of the kind of person they believed themselves to be. It might not surprise you then that during a remedial course, those kinds of feelings are discussed. And yes, even thoughts of suicide. A remedial course can provide a safe space for people to share the very personal and serious sides of their disciplinary experience. Just to be clear, though, in remedial courses, we do not provide therapy. And if we hear a course participant speak in worrisome ways about current thoughts of self-harm, we reach out privately to that person to discuss their safety. But in addition to other supports like therapy, 12-step groups, medication management were indicated. Learning the skill of self-compassion can underscore a professional sense of agency as they process what they have done. Interestingly, self-compassion has been studied in the arena of healthcare and has been found to be protective against burnout and stress. Other research has shown that self-compassion increases resilience and willingness to take responsibility for one's actions and significantly decreases burnout. Could Dr. AB's story have had a different or better outcome? What if, when they were first reported to HR, the hospital had taken a more investigative approach to understand the human side of Dr. AB's situation? Perhaps a trauma-informed investigation would have unearthed the underlying mental health issues, communication difficulties, and family and financial stresses that were a recipe for distressing conduct, especially at a time of extraordinarily difficult work demands. Such an investigation likely would have resulted in a fitness for duty evaluation where Dr. AB was found not to be fit, but under different circumstances, where Dr. AB would have felt supported and advocated for by their employer. They may have been able to take a leave of absence from their job while their mental health issues were being addressed, and if so, they could have arranged for coverage for their patients and achieved some closure with patients and coworkers. Dr. AB might have avoided the suspension of their license with the subsequent loss of income, DEA registration, and Medicare enrollment. They may have been able to preserve their reputation in the institution, community, and family. And their employer could have avoided costly recruitment and onboarding expenses. What actions can you take to create better outcomes for the public, clinicians with distressing conduct, and yourselves? I hope that Dr. AB's story and my comments have given you some ideas. First, trauma-informed approaches to investigations and employee relations. CLEAR, the organization I mentioned earlier, provides excellent formal training programs that offer certificates for investigators. We at PBI Education also provide in-services on integrating a trauma-informed approach into medical staff services and PHP processes. Another idea is to practice self-compassion. There is information on how to do this readily available on the internet. We also provide guidance in this area, including specific communication strategies for employers and professional health programs. Self-compassion works best when it includes buy-in among the entire staff of an organization, and when the organization puts systems in place for self-care of those who are in the difficult position of dealing with clinicians with distressing conduct. And finally, restorative remedial education. Remedial courses that require open self-disclosure and are intensive enough that course participants have an opportunity to develop insight are extremely valuable components of intervention plans to support otherwise worthwhile professionals. A course that requires the participant to develop a concrete plan to follow as a roadmap for the future is particularly helpful. And a course that offers a longitudinal follow-up program keeps what the participant learned fresh in their minds, perpetuates a sense of community that can decrease their feelings of isolation, provides a forum for learning from and assisting other course participants, and gives them opportunities to try out and refine their protection plans. So that concludes my prepared remarks for you tonight. I thank you so much for this invitation and for your time and your attention. And now I welcome your questions. Thank you very, very much.
So thank you so very much, Dr. Caldicott. This was so such a good explanation of I think hope, which I think is so important.
Yeah.
We do have a question here. What do you do when a physician has risk factors and vulnerabilities and is falsely accused by a patient who is a licensed attorney formally trained in counterintelligence, thus triggering an avalanche legal and board charges? It's quite a question there.
That's a really complex scenario. So I'd say you've got two things going on. And so if you recognize the clinician has risk factors and vulnerabilities, then provide them with the interventions that they need. Come up with a performance improvement plan, remedial courses or coaching, PHP involvement. I mean, whatever it is that you think, there are a number of items I listed on one of those slides, whatever you think will be in combination, because one single intervention is never going to be enough. So lots of things in combination to come up with a way of helping that clinician learn how to manage their risk factors and vulnerabilities and behave more properly going forward. And then deal separately with the accusation. And with that, you're going to need incredibly good investigators. I don't know what sort of institution you're in and what sort of investigators you have at your disposal, but I say that the quality of the investigation has to be top notch in order to be able to separate, so the physician you're talking about might be a really easy target. And so try to separate, okay, yes, this clinician might have some issues and we are addressing them and they're complying with the program. And then look very carefully at the allegations, gain as much data as you can. Even in a he said, she said kind of situation, there's often corollary information that you can assemble to create a fuller picture. There are really great firms that do investigations, independent firms, and if you wanted to message me privately, I'd be happy to point you in their direction. CLEAR, the organization I referenced a couple of times also, can be very, very helpful in that regard to steer you towards really good investigation firms. But it sounds like with such a complex situation and such a savvy complainant, you really need to protect your institution and protect the clinician and protect the patients as well as you can.
Thank you. You're getting a lot of very positive comments here.
Good.
Thank you very much. That was great. This was incredible and very, very enlightening. Thank you. Thank you for the presentation. Thank you for your answer. Thank you for a great answer. Lots of thank yous. And then we also have thank you for a great presentation. How do you typically structure the fitness for duty exam? So this is one of the things that PHPs oftentimes are asked to do. We've certainly kind of been in that territory as well. But I know, Catherine, you've got some ideas about this as well.
So we do not do fitness for duty evaluations. However, that compendium, the document from FSMB, their directory, I'm searching for that word, the directory of assessment and remedial programs is 30 some odd pages long. The first, I think, 8 pages are all assessment programs. They are nationwide. There's not a huge number of them, but there is certainly enough to choose from. They're all quite reputable. And so I would highly recommend just going to the FSMB website, fsmb.org, type remedial programs into the search bar. You'll get the entire document. I think it was, the last iteration was only from either September or earlier this month. So it's quite up to date. So the first many pages are assessment programs, and then the whole rest of it are remedial programs. So you should have some good fitness for duty recommendations on that directory.
And I do want to say that the Maryland PHP facilitates those. So, please feel free if you have someone that's working with you, someone you know, or even potentially if you're feeling like you need that sort of support, contact us. What we do is an assessment, kind of full on, and then make recommendations around where we think it might be, kind of best given the situation that the individual is in. We oftentimes are referring people to PBI. We refer a lot of folks to PBI for courses, as well. But please, if you've got questions about that, feel free to reach out to us. Certainly, the SFMB has a great resource there. But if you need a little bit of hand holding through the process, and that's certainly reasonable, please do. Can a physician in trouble ever expect to get a fair shake from the institution's HR?
Oh boy.
It's a good one.
Yeah, I think that depends on a lot of things. I think it depends on the culture of the institution, the sophistication of the HR staff, and the physician's history in the institution. Are they an upstanding member of the medical staff and then something has changed? Or is this somebody who has been sort of a thorn in everybody's side the whole time they've been at the institution? Because of that scenario of somebody who's kind of a thorn in the side, I don't know that the HR staff, as professional as they may try to be, may have difficulty giving that physician a fair shake. The flip side of your question is also true. If this is a physician who has some kind of clinical subspecialty that brings in lots of patients, or does perform some kind of service that is not widely available, and so is, for lack of a better term, a revenue stream for the institution, sometimes people look the other way when they behave badly. So they may be getting more than their fair shake, at least initially, but then their behavior is allowed to continue. Their improper behavior is allowed to continue. They can get away with it until at some point somebody is going to say, wait, enough is enough. So there really are a lot of variables in that. And I don't know that I can give you a more straightforward answer than that.
Okay, thank you. Are there more questions, comments? Again, thank you. Great speaker, great presentation. Many thanks. So we've had some really, good feedback here. Thank you so much. Any other questions before we say goodbye this evening? Okay, well, I know that all of you are going to join me in thanking Dr. Caldicott for this absolutely wonderful presentation. Again, so much information, so much really good information, but so much hope there. There's so much that can be done that I think is so important to remember. So thank you very much, but I also want to send a ton of gratitude out to all of you in our audience.
Yes.
Thank you so much. Thank you so much for being here tonight, for supporting Lemons to Lemonade, for supporting the Maryland Physician Health Program, the Center for a Healthy Maryland. We really look forward to a robust 2026 slate of topics and speakers. Maybe we can twist Dr. Caldicott's arm to come back at some point, which would be wonderful. But please look for our notices. We'll be sending them out about the upcoming lectures for 2026. Please also continue to support us by making a donation to the center. That would be wonderful and really much appreciated. Join us at Macy's. Join us at Blue Pit Barbecue. Hopefully, you all saw the stuff in the waiting room slides. Again, thank you so much, Dr. Caldicott. Thank you so much, audience members, and have a wonderful, wonderful evening. Right.
Thank you too. It was my pleasure.
Bye.
Good night.
Good night.